It's very awful when somebody introduces a great speaker. The only way is down from there, really. Thankfully, the good thing is I'm not here to speak, I'm here to chair, so you're going to hear very little from me, except just a couple of introductory comments. First of all, to say a really big thank you to the Irish Forum for Global Health for inviting me to be here with you today. It's a real honour and a privilege. We have been engaged with the forum for many years, primarily through Dr. Anita Friel, who is a force of nature within Oxfam, and I think here too we're very fortunate to have Anita. Unfortunately, she's in Rwanda this week working on some health advocacy related issues as it happens, so regrets not being here, but certainly she is our lead and our influencer and a very strong thing. I do feel like a bit of an imposter because it turns out that my picture is in the strategy, which doesn't feel right, seeing as the level of engagement I've personally had hasn't been quite where it should be, but I promise I'll try and make up for that. But it is, as I say, it's a real honour to be here with you today, and thank you very much. I'm going to introduce the panel, but before I do that, I just wanted to say that as an organisation that tries to put women at the heart of everything we do, I am a little bit perturbed at the nature of this particular panel. I'm sure all really great people, and they are, and you'll hear from them shortly. But I have a policy of never speaking on what some people call a manel. But I am assured by the Forum for Global Health that there was a lot of effort put into having a better gender balance, or having a gender balance. But unfortunately, there were a couple of speakers who couldn't make it. I was at the Women's Leadership in Global Health session upstairs just a little while ago, and to try and make up for our lack of balance, I'm going to give priority to women in the audience to engage in the discussion afterwards. So that's as good as I can do at this point, so apologies, and I hope you'll forgive us. I suppose this session, and I love the title, Importance of Integrated and Inter-Sectoral Programs, Adaptability and Sustainability. For those of us who don't live and breathe that to the same extent, I mean, to me, it's really about how do we consider everything else outside of pure health that affects health. And there are so many issues that are connected to our health, to health in a development context, that need to be considered, need to be embraced by those working on health issues. My own personal experience of it was I ran a large health program in South Sudan a number of years ago, and we worked out very early on that there was no point in trying to run a health program in South Sudan unless you were dealing with water and sanitation as a very basic additional to that. So what we're going to talk about today is to look at all of those other issues outside what is traditionally considered to be pure health. And we have speakers. We're going to talk about environment, water, sanitation, air pollution, and equitable access to all of these things, and how central it is to people's survival, to their ability to survive and come through disease and to thrive. And so that's kind of, for me, that's the kernel of what we're here to discuss today, and I hope you'll find it to be an interesting session. I also heard that the last day and a half, and congratulations to the Forum for managing to pull together such an interesting agenda for 2 days, has been hugely energetic and positive and powerful. So I encourage it to be the same. I know you've just had lunch. I know we're on the last lap, but please keep that level of energy, because it is, we bounce off each other, we learn from each other. We're here to network and to understand where we're all coming from, and it's very much a learning opportunity for everybody, including myself. So I'd encourage you to keep up that powerful spirit. So I'm going to introduce all the panel members at the same time, if that's okay. It'll help to move things along, and I'm going to edit their very lofty and impressive biogs and CVs, so forgive me in advance for that. So Martin Fitzpatrick is the Principal Environmental Health Officer with Dublin City University. He's a graduate from Trinity College, a science graduate. He was seconded to the World Health Organization way back when. He probably will tell us about that. And then came back as the Environmental Health Officer here. Since then, he also worked with the Department of Health and Children as Environmental Health Officer. He's worked as a consultant and author to the WHO and the United Nations Development Programme on environmental health projects in Europe, Indonesia, Latvia, Kazakhstan, and all over the place, really. He also has spent some time post-tsunami in Banda Aceh, and he has been the Principal Environmental Health Officer with the Air Quality Monitoring and Noise Control Unit of Dublin City Council. That's a great thing to have on your business card. But he's hugely experienced, and we're looking forward to hearing from Martin. Ben Heaven-Taylor is formerly from our parish. He was the operations manager for our colleagues across the water at OGB. He has he's 20 years of development experience in both humanitarian and development. He's a practitioner, I suppose he'd like to describe himself as. He's currently the CEO of EvidenceBased, and we're looking forward to hearing from him. Dr. Israel Balogun is very welcome. He is studying international comparative disability law and policy at NUIG, or as those of us who were there a long time ago used to call it, University College Galway. Lucky him. He worked as the DID advisor in Nigeria prior to taking up the Roger Casement Fellowship, and has great experience with DFID disability programming in Nigeria. He describes himself as a physically challenged post-polio survivor, a medical doctor and public health practitioner. And I've heard he is quite energetic and animated about the things that he really cares about. So we're looking forward to hearing from you, Israel. And finally, Dr. Peter Harrington, who is from the Gorey-Malawi Health Partnership. Peter has he trained as a GP 30 years ago. Am I allowed to say that? Yeah, I've done it. He also worked at the Mercy Hospital in Eldama Ravine in Kenya. In the 90s, he was a lecturer here at the RCSI in the Department of General Practice. He is a practice owner in Gorey in County Wexford, and he has in recent times been very involved in in fact setting up the Gorey-Malawi Health Partnership, and we're looking forward to hearing maybe how he bridges the work that he does here and the work that he's done in Malawi.
When I was asked to speak at this conference, I suggested that I would talk in relation to the take-home messages from the first global conference run last week by the World Health Organization on air pollution and health, which you would hope as an optimistic person is going to be a milestone in terms of going forward. I'm not sure how many of you were in the audience last night in the Mansion House for the climate change lecture, but I think after that I should actually rename my presentation today as Reasons to be Cheerful. And to maybe strike a note of optimism in terms of what I have to say. So my first slide, if it was up there, would be basically talking about some of the facts, and I don't want to spend all and I have a timekeeper here who told me she's going to be very strict. I don't spend it all giving you facts, but let me just give you a couple which were reiterated at great length last week in Geneva. First of all, there are 7 million deaths a year globally due to air pollution. 4 million of those are due to ambient air pollution. Over 3 million are due to household air pollution. One of the things I learned last week, there's no such thing as indoor air pollution anymore. It's a false dichotomy. Indoor becomes outdoor. It kills you either way. So a very significant health problem. 93% of our children globally are breathing air which is in excess of the WHO guidelines. And air pollution is the second leading cause of non-communicable diseases, and if you look at the burden in each of those major ones, it is very extensive. You're all medics, you know this. I don't have to spend too much time telling you about this. So what we saw last week was a very clear stating of the facts, and one of the things that emerges from that is we have enough evidence to work with. We can spend a lot of time gathering more evidence, better evidence. Let's work with what we have. In terms of some of the comments and stories that were been shared last week, I've been trying to kind of garner a few. So, for instance, the Secretary General of the World Health Organization Director General has described air pollution as the new tobacco. One of his colleagues basically made the analogy that the air has become the new open sewer, where 150 years ago we dumped stuff unwittingly into our water, and now we're doing it into our air. One of the very clear things that has emerged, and I think in terms of resilience and adaptability, is the central role of cities. We are becoming an increasingly urbanised population globally. So while it's not the whole answer, we've got to look at cities, and as someone who works in a city for a city, it's obviously something close to my heart, but we've got to see how we can work with cities, because cities are on the front line. One of the great sound bites from last week was, mayors are the new ministers for health. Now, I know a couple of people in Ireland might think, have you met my mayor? And I might have said, but it actually shows up part of the issue here in Ireland in terms of the strength of our local government. But certainly globally, the role of mayors and politicians working locally as agents of change is seen as very important. One of the very clear messages that came out from last week is, cities are where policy and people meet. And I think that's a phrase you're going to hear a bit more over the next couple of years. I've just come from another conference that's happening about 300 yards away, the Health and Wellbeing Conference by the Environmental Protection Agency and the Health Service Executive, and they're talking a lot about green space and blue space. And one of the phrases I heard last week that really resonated with me is, you can measure the depth of democracy in your city by the width of the footpath. And I think I think that's something we're going to see emerging in the next couple of years. We had a very impassioned intervention from the leading thoracic surgeon in New Delhi, and he basically made the point that when you look at air quality in New Delhi and you compare it to smoking, everybody in New Delhi, when you look at PM 2.5, everybody is smoking the equivalent of 7 cigarettes a day. That's children in the womb, including children in the womb and the newborn. During the worst episodes during the year, that goes up to about 16 cigarettes a day. So that's quite a stark picture. Okay, I said I was going to be optimistic. Let me be optimistic. Okay, I'm getting there. Okay, so the big, just to say that the big message last week from Geneva World Health Organization is there is reason for optimism, and particularly in relation to the area of climate change. Because what's very clear is if we can use air pollution and health as the driver for change in climate change action, what we can demonstrate is that the benefits are near-term and local. And God bless our politicians all over the world. They love near-term and local. And this is something that we as health workers, but all sectors, need to mobilise and get behind that message. Harking back to what I said a moment ago, and it's something that's come home very clearly to me, particularly in global terms, air pollution is a gender issue, particularly when you look at the issue around clean cooking around the world and the production of clean fuel. It is very clearly a mainstream gender issue as well. And again, that's something we need to take on board. So, so you might think that's a lot of nice talking that happened last week. What's actually come out of it? So, kind of hot off the press, basically the situation is the World Health Organization and the family of UN agencies have committed that by the year 2030, we will see a reduction by 2/3 in that 7 million deaths. That is ambitious. By any stretched imagination, that is ambitious. There's no silver bullet to achieve it, but there's a number of things that will have to happen. One of them is we've got to get back to the realization that breathing clean air is a basic human right. We've already established universal health coverage and issues around water as basic human rights. We now need to add the right to breathe clean air to that. I mentioned earlier clean cooking, and we're surrounded by the SDGs here. Clean cooking is one of those issues that is very much a cross-cutting issue across all of those goals, and that is something that the UN agencies will be prioritising, and there were very strong commitments from a number of governments, some of them quite surprising. The US government made some very strong public commitments last week in terms of supporting clean cooking technology. One of the reasons why I'm here today is to talk about promoting health workers as agents of change in the whole field of air quality, air pollution and health. Because while no one sector, no one profession owns this subject, we all have a stake in it. There was a point made last week where You know, if you have enough of an income and you're living somewhere where there's an issue with water, you can go out and buy bottled water. You can't go out and buy bottled air. So right across all segments of society, we've all got a dog in this race. One of the issues that we're going to have to address, and it very much plays to the area I work in, is building capacity in terms of air quality monitoring globally. If you look at the map of air quality monitoring across the globe, it almost mirrors poverty. Those of us who've got the money do lots of it. Those who have too much money do too much of it. But there are huge swathes of blank desert on that global map, and we need to fill in that gap. One of the things that's come across very clearly in relation to that is, in developing countries, they cannot wait to have the incremental change that we had in terms of our capacity. We've got to look to the new technologies in terms of leapfrogging technologies, in terms of the new sensoring techniques that are coming on board to be able to do this quicker, cheaper, smarter. One of the other strong commitments that we've had from the WHO is that there will be a trust fund set up for environmental health. So they're actually looking for governments and private sector to put their money where their mouth is in terms of supporting this work. And one of the things that emerged that wasn't there at the beginning of the week, but emerged through the week, and I think it's probably long term, it's a slow burner, no pun intended, but it is an important one, is to develop an international convention on air quality. And you might think, okay, so what? But if you look at what conventions have done elsewhere, in terms of greenhouse gases, in terms of what we're trying to do on climate change, it is moving the oil tanker in the right direction and heading in the right direction. And that was quite an important development last week. It's all very well to talk globally, and I've got 2 minutes, I'll take one of them. The last message I want to leave you with is, and this is part of where, as health professionals, we can actually work together. One of the major campaigns that's ongoing at the moment is the Breathe Life campaign. If you're not aware of it, go online, Google Breathe Life. WHO, just to explain, the Breathe Life campaign is where particularly cities will commit to getting their air quality in line with the WHO guidelines by the year 2030. There are a number of cities signed up to that already, but not near enough. Basically, what WHO want by 2020 is that we will have 500 cities globally signed up to Breathe Life, actively working on getting air that is clean for health. And I think in the context maybe of what we heard last night, hopefully that gives you a little bit of optimism. Thank you for your attention.
Good afternoon, everyone, and thank you very much for having me here. I'd like to, before I start, I just participating in this morning's sessions, listening to some of those discussions, I think there was I'd really like to pick up on a couple of themes that really came out quite strongly from those, particularly around, obviously, the development, humanitarian nexus and the need for longer-term perspectives on what might apparently appear to be short-term issues, that the fact that that's not really a sustainable, the fact kind of focusing on short-termism is not a truly effective way of addressing crises. And the other really being around effective partnerships for humanitarian and development over time, and the fact that partnerships for health, and particularly from my perspective, working for a research into practice organisation, partnerships for around evidence are really potentially powerful ways of delivering change in many of the world's most challenging environments. So just a little bit around the organisation I work for, EvidenceAid. So we were founded about 10 years ago now by a group of medical researchers primarily from the Cochrane group, who were keen to see how they could use medical evidence in humanitarian settings, and to take, if you like, the global evidence base around what works in medical interventions, and to try and apply that in resource poor or crisis settings in the global south. As I say, there's very strong links to the Cochrane collaboration, but the primary focus really was to collate and get into use systematic reviews from the Cochrane Library and from other sources to create kind of practitioner-orientated materials to influence the effectiveness of humanitarian program design. So we engage with humanitarian actors. My background is humanitarian practitioner. I feel like a bit of an imposter, just to pick on what Jim said earlier on. I'm not a clinician, I'm not even a researcher. I come from a practitioner background. But I think it's really important that there are organisations like EvidenceBased which sits between if you like, the research community, the evidence generating community, and the practitioner community to try and ensure that the research that's being generated is getting into practice. So ultimately, our aim as EvidenceBased is to save lives and livelihoods by supporting what we call evidence-based humanitarian action. Evidence-based humanitarian action is, in my view, not simply taking the evidence base and slavishly trying to follow the path that you're being pushed along by what the evidence is telling you, but using the best available evidence and using it as one pillar, if you like, in a decision-making process, which should also include also obviously beneficiary feedback, people you're working with, actually asking them what they need and what they want, picking up on, again, on some of the themes we heard about this morning. Practitioner knowledge, again, really important that actually you listen to the people who have knowledge of the context where you're working, and who may know what kinds of interventions might work in a given context, and also picking up on contextual analysis and the practicalities of the environment where you're working with. So if it's actually not physically possible to do a particular intervention, even though the evidence base is telling you to do it, what do you do? And triangulating all of those different things with the very best available evidence that you can get hold of in any given context. So that's kind of the theory of what we do. But I thought in order to try and illustrate what I'm talking about, I'd take a practical example from my own experience, the one I want to focus on is cholera prevention, which was something I was involved with on several different occasions in Eastern DRC in the early part of last decade and towards the latter part of last decade as well. And I think the mere fact that I found myself doing it several times and very often doing the same things on several different occasions reinforced to me the importance that this was not a short-term crisis issue, and secondly, that we were not learning the lessons either institutionally or globally from doing these repeated short-term quick interventions to individual outbreaks of cholera. So just a word about kind of cholera and transmission for those who don't know, who aren't familiar with it. So it's caused by a bacteria or a Vibrio. WHO estimate there are typically between 1.3 and 4 million cases a year, which result in anywhere between 21,000 and 143,000 deaths in any given year. The Vibrios are transmitted via fecal-oral route. It's usually transmitted in contaminated food or water. The effects, the symptoms are induced by a toxin released by the bacteria, which can induce acute diarrhea or vomiting, and which can lead to acute dehydration, and if left untreated, can cause death. It takes a fair number of Vibrios to actually produce clinical cholera, and it's interesting to note that between 60 and 90% of infected individuals are asymptomatic or have very mild symptoms. However, the risk of infection is greatly increased in many resource-poor settings where there is poor water and sanitation, by the presence of microscopic crustaceans called copepods in the water supply. And unfortunately, these act as little magnets which kind of attract the Vibrios to them, and they greatly increase the chance of transmission where they're present in the water supply. So between 1 and 10 copepods are estimated to be able to carry enough Vibrios to produce clinical cholera. It's actually incredibly simple to treat cholera, primarily by oral rehydration. Severe cases may require intravenous fluids. You may use antibiotics to reduce the severity, but primarily it's about ORS and the administration of it. And with prompt, appropriate rehydration, fewer than 1% of cholera patients die. But without treatment, mortality rates are vastly increased. But I don't particularly want to, I'm not going to focus on cholera prevention because that's not primarily where I worked. I want to talk more about how you prevent it. Most cholera prevention interventions done by development humanitarian actors in the global south focus on water sanitation and hygiene promotion, or WASH for short. So that's improving water quality through construction or rehabilitation of water sources, through water treatment, or importing clean water, so water tankering, those sorts of interventions. Also by improving your sanitation in a particular environment, so constructing facilities for the safe disposal of excreta. And by public health and environmental health promotion in affected communities, so often focusing on the safe storage of water in household settings. And also improve behaviours around hand washing and safe food preparation. To go to my kind of current focus at EvidenceAid around the evidence base. So what's the evidence base for doing WASH in response to cholera, or in attempting to prevent cholera? Well, there's actually a reasonably strong but fairly patchy evidence base for the effectiveness of WASH interventions in terms of reducing the risk of cholera. There's a reasonably strong evidence base around some interventions, such as disinfection treatment of water sources and household-based water treatment, so things like chlorine tablets. But other interventions under the umbrella of WASH are not actually fantastically well supported by the evidence base. There's a moderately good evidential base for household-based health promotion, including hand washing. And actually, one thing I'd point out, within having knocked around the humanitarian sector for a fair few years, actually systematic reviews and strong evidence base was actually one of the reasons why health promotion was introduced into the mix sort of around 20 years ago, 30 years ago, alongside the kind of more technical water and sanitation-based interventions. So an example, you think, of evidence-based practice. But I would say, generally speaking, humanitarian actors or actors in this area do not see their interventions particularly in terms of disease risk reduction. The dominant paradigm, I would say, in humanitarian settings is still around fulfilling basic needs. So people talk about fulfilling the basic need for water, fulfilling the basic need for sanitation. Although some areas are well researched and have a good evidential base for action, there are some really significant gaps in terms of the evidence base. So actually, for instance, there isn't a particularly strong evidence base around latrine building and whether that genuinely has an impact. And what particular kinds of interventions are most effective. And I think the fact that we continue to do that anyway, without particularly challenging ourselves to be more evidence-based and more robust in terms of our action, is partly to do with this kind of dominant paradigm about meeting needs rather than actually addressing risk. I think there's also an issue that even where we are evidence-based in terms of in a global sense, we're not always particularly good at looking at comparing and using both the local evidence base, if you like, and the global evidence base together. So what I mean by that is that what may be true globally, based on systematic review evidence, for example, may mask actually the true drivers of disease transmission in a particular locality and result in interventions which fail to address a given specific outbreak. So in Eastern DRC, for example, if you're, which is the area that I'm most familiar with, you potentially you're masking some of the local factors behind disease transmission. So in DRC, cholera is a fact of life. I've been in one way, shape or form involved in humanitarian response and cholera response in Eastern DRC for, I suppose, around the last 20 years, all in all. It's endemic, and it's something which we continually respond to. And indeed, last year there was a particularly severe outbreak, which resulted in over 1,000 deaths. WASH is a really integral part of the way that the humanitarian community deals with cholera in Eastern DRC, and the focus is, largely on prevention via household-based water chlorination and health promotion. But the actual mechanism of transmission in DRC is really poorly understood by the actors who are working in WASH in that area. And it's not helped by the fact that there's a lack of access to systematic health data in that particular locality. Actors can, and some do, go digging for health data, but we're not, I think the kind of imperative to do something, to act, often overpowers the kind of imperative to actually seek out a strong evidence base for what we are doing. But actually, if you look at the health data in Eastern DRC, there is a really strong correlation between proximity and contact to surface water and cholera infection. So many of those who get sick in Eastern DRC, at least in the outset of any given cholera epidemic, tend to be fisherfolk, herders, people who go paddling around in water, essentially, or people who wash clothes in rivers or otherwise have interaction with surface water. So it's only really by comparing and contrasting the evidence base which you are able to collect locally, along with a global evidence base, that you can really come up with a sensible approach, a sensible response to this particular disease in this particular locality. So what does this mean? I'm not arguing that we should stop doing water and sanitation health promotion in Eastern DRC. I think WASH interventions properly implemented, they're really unlikely to do harm. You're not going to actually harm people by doing them. They may well be beneficial, and it's a good first response. So if there's if you're needing to respond quickly in an emergency, it's strongly supported by, at least in part, by robust evidence. But I think what I'm saying is we shouldn't stop looking for other risk factors. And I think often we begin and end with WASH response, and we don't go any further, and we don't look into the drivers of what's causing a disease in any given context. So in Eastern DRC, the local data suggests we should be looking at interventions around surface water. So should we pay fisherfolk to stop fishing? Should we be offering other incentives to stop interacting with surface water? The Burundian, interestingly, a couple of years ago, the Burundian government simply stopped people, forcibly prevented people from going into the Ruzizi River, and actually stopped a cholera outbreak along the Ruzizi River as a result. I'm not arguing we should be working in close partnership with the Burundian government, Burundian army, but I think that we should be exploring other forms of intervention which could have a more immediate impact on cholera transmission. Can we do better at designing interventions which are more sensitive and more responsive to local risk factors? Just in terms of kind of what was being talked about earlier today around resilience, I think one of the things which this says to me is that the crisis approach to diseases like cholera is it's not effective, and it's actually pretty wasteful. As I was saying earlier, cholera in DRC is endemic and it's cyclical. It was happening throughout my career in Eastern DRC. It's happening to people working there now. It's a fact of life, and we need to take a long-term view of that. It's not good enough to simply say, okay, there's an outbreak right now, let's respond to that particular outbreak. So we need to be thinking about the local actors and building capacity particularly around data, and thinking about who owns the data. So neither is it, I think, good enough for international agencies to like own all the data around issues like cholera prevention, because we're peripatetic, we're temporary. Many of the staff who operate in humanitarian agencies, they come, they go, the tenure is not long. So we need to be thinking about how and if we can embed that data ownership locally. And so I think, capacity building, long-term capacity building in the collection, analysis and use of surveillance data and research is a really fundamental part of building resilience to risks like cholera in Eastern DRC. There have been attempts to do this in DRC. I'm not saying there haven't been, but they have failed they have all failed actually due to lack of sustained agency and donor interest. It's really interesting what was being said earlier on in the sessions on partnerships, and I'd like to pick up. One of the things that I took away from that was that what really matters in terms of sustaining partnerships for any kind of partnerships for long-term outcomes is the enthusiasm and the leadership behind them, not necessarily the money. And I think what we need to understand within the humanitarian development sector is how we can deploy long-term leadership, long-term enthusiasm, and really get behind long-term initiatives which take longer than 3 years, your standard project lifespan, to really improve and strengthen the local evidence base to address health risks like cholera. So just to sum up, it's not just about using evidence to slavishly dictate humanitarian action. It's about using evidence to ask more intelligent questions, triangulating evidence with practitioner knowledge, beneficiary views, and local contextual information. It's about thinking about interventions that build the capacity of local actors to collect, analyse, and act on both global and local evidence base. So that's it. These are a few resources from EvidenceAid. So as I say, we've got lots of systematically reviewed evidence that is orientated towards the humanitarian sector and towards health issues, in particular in resource-poor settings. We also have a new practice guide for humanitarian practitioners on the use of evidence. So please go and visit our website. Thank you very much.
Good afternoon, all. I really want to thank the organizers of this forum, the Irish Forum for Global Health. I would like to appreciate the Doctors Disability Inclusive Development Working Groups for their job and what they are currently doing here in Ireland and in the field of disability inclusive development. And I want to appreciate my organization here in Ireland, Christopher Blinding Mission, represented by one of my senior colleagues here, Ruben. CBM is one of the largest disability organizations in the world. We've been around for over 100 years, working in the field of disability, starting with eye health. Now we have moved to so many other aspects of health. We are into mental health, disability inclusive development, humanitarian response, and also we are working in neglected tropical diseases. So for me, as an individual, I work round the clock as a disability inclusive development advisor. And I want to also specifically thank the Irish government for this rare opportunity that they gave to me to come and study here in Ireland. I want to thank Irish Aid for this opportunity. I'm a Roger Casement fellow, and I'm happy and excited with the fellowship. Every day, I long going to school. Honestly, it has been wonderful. For me, I'm just auditing every module. And I want to encourage every one of you, if you are here, I want to encourage you to attend the Disability Law and Policy Summer School. It will give you a better perspective about disability inclusion. Thank you. We all know that 1 billion of the estimated 7 billion of the world population are living with disability, and 1 in 7 all in all. People with disability are among the poorest of the poor. 80% of them live in developing countries. And when you talk about poverty, they are the most extremely affected. You need to go to developing countries to be able to see that. with no social security, no social support. And disability over the years have undergone some transitional changes, ranging from charity model, medical model, economic model, social model, and now we are at the right-based approach, which is the major thing that we are into, and we advocate for that. A major change that brought about this was the United Nations Convention on the Rights of Persons with Disability, which came into being in December 2006, and most countries, about 177 of them, have ratified it, beginning from 2007. And I'm happy that the Irish government have also done that this year, which is a plus. And in other words, when you ratify, you also have some responsibility that you need to take and carry out. I'm interested in Article 3, 11 and 32. And in Article 3, it says, which is the general principle of the CRP, the Convention on the Rights of Persons with Disabilities. It talks about the autonomy, non-discrimination, respect for the inherent dignity of people with disability. And Article 11 talks about disability inclusion in humanitarian setting. I'm glad that my earlier presenter made mention of humanitarian setting. I've worked in humanitarian setting back home in Nigeria too. And Article 32, which talks about the responsibility of countries that have ratified the convention to play a role in international development efforts. For us in CBM, we make sure that persons with disability are engaged in every stage of our program cycle management. The next thing we do also is this, to make sure that they are not discriminated in any way. And we also make sure that their voice, their choice, their opinions, both for women, boys, girls, are respected in all our programs. And also we try to make sure that we demonstrate equal opportunities for women, boys, and girls. So, and we try to make sure that in all our programs, it is accessible for all. As you can see, this building is a little bit not accessible. So, we need to work on that. Thank you. This is the approach we're going to use, which we promote, and we encourage other people to use it. Like, when you talk about disability inclusive development, persons with disabilities have their voice, dignity, choice, and autonomy respected. They are effectively supported to participate and be fully included in their community as equal citizens, not second class, not third class, not relegated to the background. If you go to developing countries, some of them, you won't even see them on the street. They are hidden, tied down behind, hidden from the general public because of the stigma and discrimination associated with disabilities. We don't want that. And we also want the government to make sure that they put in the necessary policy framework and legal instrument that will protect the rights of persons with disability. And appropriate budgetary allocation at national and local levels are made available. And we also want the leadership to ensure that data are disaggregated by age, sex, and disability. We have different types of disability. Some are visible, some are invisible. As we all know, the medical colleagues will understand this. Not every disability is visible. Some are genetic, some are psychosocial, and we need to be mindful of that. And also, all national and international development and humanitarian programs should be disability inclusive. Fortunately, we've been laying emphasis on leaving no one behind and the Sustainable Development Goals. We had the opportunity of having 5 goals explicitly making reference to persons with disabilities. And these are 4, 8, 10, 11, and the partnership thing. However, all the goals are inclusive because we said leave no one behind, so everybody should be involved. So I'm going to give you a case scenario on how you can mainstream disability into your program and policy, which we have done back home in Nigeria. The strategies for doing this is very simple and straightforward. First and foremost, you need to identify and engage with leaders of people with disability at every stage of the program cycle management. In other words, we want participatory program planning. We don't want tokenism or tick the boxes. So you just say, okay, you invite one. Okay, one person with disability was there. Okay, yeah, his name is A, B, C. You know, we don't want that. We want them to be actively involved. And the other thing is also that we need you to disaggregate data by disability types. Like I said earlier on, we have the physically challenged, we have the visually impaired, we have the hearing impaired, we have people with psychosocial disability. We want that data to be splitted by sex, age, and the disability types. And we also want the capacity of persons with disability, organization of persons with disability to be strengthened. Because the tendency is this: when you go to the field, developmental organization, foreign donors, we say, okay, people with disability don't have capacity, but please, build our capacity. Somebody built capacity before they could be able to reach certain levels. So we need that, and we want people with disability to be involved in the advocacy drive. Don't put us behind. Don't speak on our behalf. We can be our own voices. So in this strategy, we tend to promote what we call the twin track approach, which is basically mainstreaming and also disability specific. A typical scenario is this: I'm physically challenged, post-polio survivor. You can see another post-polio survivor is also physically challenged, but our needs differ. So you need to make sure that the specifics for individual are tailored to meet their needs. And research has been done, because I'm also a public health physician. Like I said, I did my master's in London School of Hygiene and Tropical Medicine. Research has come out, and the gains of inclusion is significant. But the cost of exclusion, my God, is disastrous. Very, very terrible. I'll give you a story before I round up. We need to also train our staff on disability inclusion in programming and policy formulation, and also engage partners and funders in having interface with the donors. I saw that it worked magic for us back home in Nigeria, and I'm going to share a case study that we had. Sitting there, some of our staff and persons with disability, we had a meeting with the outgoing British High Commissioner in Nigeria, Paul Ockright. And what did we go to talk to him about? We said, okay, DFID, you've been investing a lot of money in Nigeria. But however, people with disability have not felt your impact. How can you mainstream disability into your program? He said, well, introduce us to DFID, which is the development aspect, and we met with the senior advisor. Thank you. And in the process of our interaction, we volunteered, we gave them training. And subsequently, they asked us that we should come up with a strategy of engaging people with disabilities. So one of the things we did was, we said, okay, like I said, I'm a Shivni alumni. I was sponsored by the Shivni, by the British government for my master's in London School. I said, okay, let's start with education. A practical example. Shivni scholarship, I was the first person with disability to have gotten the scholarship since 1983. And it was like, wow. I said, this scholarship is not inclusive. So I started organizing workshops for the mainstream. Then I now cone it down to making it disability specific. As fate we have it, this year alone, we had 5 persons with disability securing the scholarship and are studying in different parts of the world. And guess what? It became a pilot project for the British government. They were really impressed. They were happy with it. And I told them, I said, look, if given the enabling environment, persons with disability can maximize their potential. Don't limit us. You tend to limit us. The stereotype is just too weird. And doing something special, it's not peculiar to us. If given the enabling environment, the right support. Subsequently, these are some of the participants. Some are in the UK, 5 of them for the first time. Another thing we also did was to engage with government at the national level, meeting with state government, with persons with disability taking the lead. It's not about other without disability. I can't expect Oxfam to go and talk about poverty among people with disability and just go alone. CEO, I will expect you to carry me along and carry the leaders of persons with disability along, including women, boys, and girls, if possible. And we also try to influence policy change through participatory approach, with people with disability leading the change. This was the national policy in Nigeria, where at first they developed the policy, but we say no. Whatever you develop is not inclusive, nothing about or without us. So we changed the trend, and we sat down, we developed it, and they were happy with it because we had to introduce the human right approach to it. We don't want charity. We don't want welfare. We don't want the medical model. Actually, I have a problem with the medical doctors or the medical practitioners. Sorry, I'm a doctor myself. But I can see that we are stereotypical. In our dealing with persons with disability, we are too stereotyped. We are more of restricted by the books. I remember my consultant calling me handicapped. I almost slapped him. I'm sorry. Engaging with high-power delegation ahead of the Global Disability Summit. So this is Penny Mordant. Before the Global Disability Summit, we sat together and we fashioned out what we want to be in the agenda from our country, and it was really great. Before I conclude, why disability inclusion? Almost 10 years ago, I wrote a proposal to address HIV among people with disabilities. And the state where I work in the Northeast region, they said, how will you get HIV? Your people with disabilities, they marry themselves. How will they get HIV? I said, okay, no problem. I've gotten the funding. I took the leaders, one of the monitoring and evaluation officers, I said, please follow me. I want you to be there. So the first test we did, it was among people with disability, about 100, and 5 of them were reactive. After confirmatory tests, they were also positive. The guy just put his hand on his head. I said, what happened? He said, doctor, come. There is a problem. I said, what kind of problem? He said, you see that blind man that was positive? He used to be in our neighborhood. He used to be in our neighborhood where they live. And we just chased him out of our neighborhood because he was a pedophile. He was always sleeping and luring girls, young girls within the neighborhood and molesting them. And I said then, what is the reason? He said, it's not sure the number of people that will be HIV affected. I said, okay. I said, but you see now, you told me that people with disability cannot get HIV. Now you can see that when you exclude one, the cost can be damaging, catastrophic, indeed. I can't imagine the number of people, I'm not sure, the number of people the guy will have infected with the disease. So, inclusion is very, very important. The following year, they themselves, without anybody talking to them, they organized a workshop, brought all people with disabilities, and were training them on HIV, counseling, sexual reproductive health, and so on and so forth. In conclusion, I want to encourage you. Disability inclusion is a human right thing. It's a development thing. And morally, it's something that we should factor into all our programs. Let us not leave anybody behind. Thank you.
I want to talk about the work in Malawi that I carry out, and also very much the work of Joe Gallagher. We too are GPs in Gorey, which is a small rural town about 60 miles south of here. And when we're not working in general practice, we have formed the Gorey-Malawi Health Partnership. I should put down a writer about this. 2 huge people to thank. Without Esther, we wouldn't have got all of this done. Huge supporters and very encouraging. So thanks to Esther for our backing our work, and also one major benefactor in Gorey, Maria Medical Healthcare, who have come on as major sponsors. Otherwise, all the money we've raised has been raised in Gorey, apart from Esther. Lots of charity, mostly through the efforts of our practice staff. We also take additional workers. We're not exclusive, so we have various people joining us. We have a nurse manager, we have a clinical scientist, we have a pharmacist, and this outsiders give us this great energy in the group, and not just those of us who are GPs. I worked in Africa many, many years ago, 30 years ago perhaps. Joe worked there much more recently, but when I was in Africa, an epidemic was caused by a virus or a bacteria or a protozoa, whereas now we have a new epidemic. It's NCDs. And curious enough, NCDs are what GPs treat on a regular basis. So we went to Malawi to the partnership. Joe, having gone back many, many times to Mzuzu, we work with 2 institutions in Mzuzu, a government hospital, Mzuzu Central, and St. John's Hospital. And we said, we come from Ireland, we think we might be able to advise you about your health service. And they sort of sniggered and said, what? Not really. But I suppose we've had other better speakers than I've spoken about the Irish Health Service. Sarah Burke gave a great talk yesterday. But if I could just emphasise the mistakes, and if Malawi can learn anything from the Irish Health Service, perhaps the errors. It's not a coincidence that Ireland has a high spend for relatively modest returns when you consider that general practice is relatively underfunded, primary care is relatively underfunded. We have an increasingly specialised, subspecialised consultant and other hospital groups. And there are no generalists left. GPs are the new generalists. And if we need to have universal healthcare for Malawi, we'll need generalists. So that might be one advice they might take from the Irish model. So again, I want to move on from the Altana Declaration, but clearly I think trying to link in what I'm trying to say about asthma to how Malawi might move on with its asthma area, in keeping in mind the failure thus far to get universal health coverage. So we went to our partners in these 2 institutions and other institutions, and we went back over re-established contacts, and we said, is there an area of NCDs that we can help you with? And almost universally they said, asthma. We don't seem to know much about how to manage asthma. And we thought that's something relatively straightforward we could manage or help you to manage, because again, it's a symptomatic disease and it's relatively small compared to other NCDs. So let's start with asthma. And we thought, well, if we're starting with asthma, with the audit cycle in mind, we might just ask ourselves, where is the asthma care now in these institutions, and where in time might we reasonably expect to get to, and then what steps might we take to get there? So, starting with the idea of where is our asthma care now? One of my sadder moments in Mzuzu Central was sitting at the ward round, and a young clinical officer named Rose had been asked to present about asthma, and she presented a really good quality demonstration, descriptions of symptoms and so on. But when she came to therapeutics, she sort of served up this lofty formulary of drugs, long-acting beta-2 agonists, long-acting muscarinic antagonists, all the sorts of things that we in Ireland take for granted. And I suppose I was rather saddened, and no one challenged her, and we moved on to the cases and so on. But I knew, and anyone who had been to the pharmacy knew, that really this is fantastic, in the wrong sense of the word. It's a fable, it's a myth, and we need to start with where we're at. So where are we? Well, I hope you can see this slide okay. I hope for those of you non-clinicians, I'll broadly try and, don't worry too much, but I'll try and be reasonably clear with what I'm trying to convey. First of all, of the sort of resources that one might need for asthma, if you see that all was available, not all drugs are always available. And furthermore, what's available is frequently intravenous, high strength, and what's available intravenously. The middle column will tell us we rely increasingly on asthma management with 2 forms of drug, both of them by inhaler. So asthma is essentially inhaler-driven. You've got believer inhalers, salbutamol being the prime one, that open up the airways when you're breathless, and we have usually steroid-based inhalers, which maintain that airway open and reduce inflammation in those with chronic symptoms. So I think I'll come back to these a bit more in detail, but where might Rose have looked for if she wanted guidance about what drugs we should put into our mixture? And this is an obvious place. You start with the WHO model list of essential medicines, which is compiled for low and middle income countries. And again, this is the WHO list. And again, if you look at what's available in Mzuzu Central, unfortunately, these are the ones in red are available, you will notice that we have very few of our inhaled steroids, our inhaled airway openers are available. And in the very right-hand column, budesonide formoterol, which is this combined steroid airway opening preventer. And again, Malawi is not going to be able to afford this drug anytime soon. So I'm not too sure that model is ideal for Malawi. And you've got to ask yourself, is a formulary that's devised for middle-income countries also suitable for a formulary with a low-income country? And is it time for a separate formulary for a low-income country? When you consider that a low-income country could have an economy 1/12 the size of a middle-income country, perhaps it's time to think out that again. She could have gone to the Malawi national standard formulary, and she would have found more matching drugs in that. I want to focus on this. So the drugs in the pharmacy match this a bit more completely, but again, as I said to you, there's no guaranteed supply of inhaled drugs. So going through these in a bit more detail, salbutamol tablets, aminophylline tablets, aminophylline intravenous, very, very minimally effective drugs for asthma. Inhaled medications, we said, not available. They recommend the use of nebulizers. In a country which we learned yesterday has a 10% electricity penetration. So nebulizers are electric pumps required to pump out. So again, totally inappropriate. In addition then, another drug, sodium chromoglycate added in, which again is of dubious value compared to the more potent steroids. So I suppose it's a bad place to start when your own sort of formulary is not particularly helpful. In addition then, you have two drugs in blue there. If you look at the top of those, magnesium sulfate is available in the pharmacy, but it's not used for asthma in Malawi. It's a very useful drug. It's used to treat eclampsia on the labour ward, but it can be used brilliantly to treat asthma. So it's a drug they're not using that they could use very simply without actually purchasing anything new particularly. And then, last point, they were using a lot of intravenous antibiotics, sometimes third-generation cephalosporins. We felt quite inappropriately. Antibiotics probably not appropriate for pure asthma treatment unless there's coexisting pneumonia. So you can see where we are starting from, and it's a good place to know where you are. So continuing on our questions then, we said to our partners, we can help you perhaps starting here to move on and to improve things. And we worked back and forth with them. And in June of this year, we returned in triumph and formulated and signed memorandums of understanding with both of our partners. And this slide, I think, conveys maybe most of the key personnel involved. Joe Gallagher on the right, together with Master in the pink shirt, they were the Brexit-type negotiators back and forth, constantly liaising and creating. And that relationship is what has got us to this point, I think. On my left and right, only two physicians. Imagine a tertiary teaching hospital with two consultant physicians. That's the level of doctor penetration. But they had to be brought on side and consulted and very much involved, which they have been. On the left are two clinical fellows, both of whom are clinical officers. And we chose not to employ doctors because they're rare and they move, whereas clinical fellows, or clinical officers rather, are much more likely to stay put. So Chikondi and Temba on the left, a lot lies on the shoulders of these two men. They are key workers in Mazuza Central. Now, also demonstrate the use of Vitalograph. We brought one donor, so every good partnership is launched with a nice piece of equipment. So the second and third spirometers in all of Malawi are now sitting in our two partner institutions, with thanks to Vitalograph, who just said, of course, no problem. So, working on, we still got to find out more about where we are. We've looked at the drugs, but we have no real data on which to base progress. And so, we're sitting down with our fellows trying to work out where do we go from here. We have generated sorry, I'll come back to that. We've generated a number of ways of gathering data, which I'll move on to. We've also held needs assessment workshops to try and establish what the other stakeholders. So apart from the two institutions, we have got the Ministry of Health, we've got two nursing schools allied to the two institutions. And very interesting issues raised at the workshop, including the fact that lots of white northerners appear and take their data and then don't reappear. So they emphasize the importance of coming back and feeding back to them. We started informal liaison with the pharmacies to work out what's the issues with supply and can we improve inhaled medications. We developed inpatient and outpatient protocols for management of asthma. And we have flow sheets. So we have an inpatient flow sheet. So this is when they're admitted to the ward. This is their admission status, their clinical status, and the drugs prescribed. And that's completed to allow audit. We've got a register of all asthmatics for the first time attending the two universities, the two hospitals rather. So they're on laptops, which we've donated. So that allows us again to do clinical audit. And we have a stamp. This is a good example of North-South partnership. This started on our computer screen in our surgery. It's an aid memoir for asthma management. It contains all you need to know in a sort of a 9-10 question. And we modified it. We worked with our Malawi consultant physicians who said, change these things, add this. And we we now use it as a stamp. It's not on laptop. It's stamped onto the patient's health record and filled out at each asthma contact. And Chikondi and Temba are tasked with moving the other staff at the hospital to an inhaler base. So their job is to try and teach a change to inhaler-based therapies, and this is Chikondi trying to show us that. So where might we easily expect to get to? And maybe this is kind of the nub of what I have to say. When you move to your formulary, we need to get more like this and not more like the lofty formulary that Rose imagined. It's not very sexy, but it works. And the good news is, you know, salbutamol, which is the airway opener, the Asthma Society in Ireland says you take, if you're breathless, very breathless, you take a 1 puff every 1 minute till you're not breathless. Very simple, very simple. Repeated doses of salbutamol inhaler, given if necessary by spacer, are life-saving. Spacers. We learned, again, from clinical evidence and evidence-based that nebulizers are no more effective than manufactured spacers. And the other good news is a properly manufactured bottle spacer that's tightly sealed is as good as a manufactured spacer. So these are really helpful. So if I was to give one message to Malawi in terms of a universal asthma management, these are the golden 6. There's only 4 drugs. 2 of them are spacers, so salbutamol inhaler and the bottle spacer I talked about. In addition, a baby spacer is needed for tight seal for infants who can't put their lips onto a bottle. You need rapid availability for oral prednisolone or oral dexamethasone, which are steroid tablets to rescue your asthmatics. You need 1 ampule or some ampules available of magnesium sulfate for very severe asthmatics available intravenously. And you then, for those with persisting symptoms, you need probably beclomethasone inhaler. So we could, by adding beclomethasone effectively, by cutting out some of the stuff that's available intravenously in our pharmacies at present, we could, by rationalizing, actually have a much more effective system. So I would suggest for Malawi, if 95% of the health workers from the lake to the health centre to the district hospital to the central hospital had this, and the first professional, the first contact, be it a healthcare assistant or a nurse or a clinical officer, had these skills, we would have much, much better asthma care than if we had a small number having second, third line medications. So what steps would we need to take to get there? We do maintain contact via Zoom technology. So this is Hastings, our other man, he's in St. John's Hospital. He's talking to Joe and myself, and Mark, our pharmacist, is sitting in Ireland in 2 different locations. We use Zoom technology to allow case presentations. So they present a case to us. We go through management aspects and perhaps learning points. So it's a clinical mentoring feedback that builds the relationship between us. And these 3 workers are key. If we can keep investing in them, we hope that they will drive the change in their own institutions. The future, hard to know. Maybe a research arm. We'd like to help with educational opportunities, and we are already supporting a PhD student at present. We need to start audits shortly to see exactly where we are and what's changing, and we need to rapidly cycle the audits to try and improve things. And I suppose we're also looking forward to visits from our partners and our clinical officers to Ireland in the near future. Thank you.